Good afternoon, everyone. Welcome again. This is the course on infection prevention and control, and this session is going to be about surveillance for hospital-acquired infections or healthcare setting-acquired infections. I'm Dr. Samiksha Singh from Indian Institute of Public Health, Hyderabad. So let's start with our session. Surveillance, we have mostly known as public health surveillance, and but it has much use, in fact, a lot of use in hospital settings also. So today we will be seeing how we apply these principles to hospital acquired infections. So our main learning objectives for this session are to understand the principles and types of surveillance for healthcare settings, to learn steps in surveillance and interpretation of the information that we gather from it, to recognize the importance and requirement of a proper surveillance system in our hospitals. And at the end of this session, you should be able to start surveillance for key infections in your units. As I mentioned, we know surveillance for public health surveillance. So, as per that definition, it is an ongoing, systematic collection, analysis, and interpretation of health related data essential to the planning, implementation, and evaluation of public health practice, closely integrated with the timely dissemination of these data to those responsible for prevention and control. So if you look here, it's not just about collection of information or analyzing or interpreting. It's a whole system which feeds into the planning and implementation and evaluation of your programs. It involves timely sharing of the information with the people who can benefit from this information, who can take decisions at the right time, and who are mainly responsible for the prevention and control activities of the disease in concern or the risk factors in concern, whatever we are surveilling for. Now, if we apply the same surveillance for hospital settings and we use it for healthcare acquired infections, so the surveillance of healthcare acquired infections sets up a foundation for any organization in organizing, implementing, and maintaining an effective infection prevention and control program in the healthcare facility. We'll see how it helps, but you have to understand that if you want to control healthcare acquired infections, you first need to know what to measure, how to measure, and then only you can plan to control. And in fact, you can also prove later on that how did you manage to improve it. So measuring is very important and the first step towards any control program. Now, why do we need surveillance for healthcare affected infections, right? There are multiple problems which are coming up, and if we don't keep a track of them, we are likely to not address them. We all know that antibiotic resistant organisms are increasing day by day, especially, and these are more in in healthcare based infections, and they affect the vulnerable and immunocompromised population more, and they are increasing. Healthcare acquired infections, they also add imbalance to the resource allocation. We allocate resources in hospitals and healthcare facilities to be able to cater to the people who are coming with the diseases. Here, if we do not control for these infections add to the burden of the disease as well as take away a lot of resource which could have gone in otherwise treating the patients at the community level or coming from the community. Evidence shows that if you implement a good surveillance system and link it with infection prevention and control practices and monitoring over a period of time, you see reduction in these healthcare associated infections. Surveillance also helps monitor the effectiveness of the interventions that you are taking. It's simultaneous because it's an ongoing practice. So ongoing you can look at what are the practices happening, what are the outcomes coming out of those practices, and can help you in continuously monitoring and making your decisions for program management. Surveillance for healthcare acquired infections can be highly useful for identification of outbreaks, which are sudden onset in nature of known or unknown infections. And once picked up early, they can prevent the spread from one patient or infected patients to other patients, as well as we can prevent the infection spreading to the healthcare staff. So, as we said, measurement is important. So we focus on establishing such a system. So, if you want to establish a surveillance system for healthcare acquired infections, so overall aim is to reduce the burden of healthcare associated infections and also reduce the associated costs. So, what the purpose is, the specific objectives are to monitor trends, incidence, and distribution of healthcare acquired infections, the prevalence of those infections, and the associated risk factors. Once we know the risk factors, you can also plan to control those risk factors, to identify need for changes in control measures and inform healthcare providers and decision makers. Most of us already take control measures in place so that the infections do not spread. However, if you do continuous surveillance and if you see changing trends, you can use that information to change your control measures. Most of the surveillance is managed through microbiologists or sanitary inspectors or hospital prevention control committees. However, it is very important that our objective should be to engage clinical team to adopt evidence-based best practices and monitor them, because it's where if there are any gaps and lacunae, infections can spread. We should be able to use this information to prioritize the areas where the resources should be allocated in terms of prevention and as well as cure. Surveillance can also be set with the long term goal of evaluating the effectiveness of interventions in reducing hospital acquired infections. And it can also help you to compare the rates within the hospital, as in between the wards, and between the hospitals, hospital A and hospital B, to see what are the current rates of healthcare acquired infections, so that you know, is it your hospital standalone which has high rates or your better performing hospital, and look at your own performance. So, with this goal and objectives, we look at setting up the surveillance system. Now, coming to the types of surveillance, there are broadly two types of surveillance, passive and active. There's something also called sentinel surveillance, which is for very rare diseases. But for healthcare acquired infections, in practice, mostly you may use the passive surveillance and active surveillance. Passive surveillance is records based. Usually, you have records, and periodically, you can just look at your records and keep a track of, look at your data of what kind of patients, what kind of diseases, what kind of infections have been noted, and how many of them can be attributed to the healthcare acquired infections. Other is that you actively look into the incidence or prevalence of disease in concern or infection in concern, where you actively develop a methodology to collect information. If you do it prospectively, it will be an incident survey, and if you look at the records at the back, uh, but you will actively search for it, that is prevalence. So, amongst the key strategies of surveillance, you know the types, but if you have to do it, the key strategies you have to keep in mind is, what are you going to do surveillance for? That's one thing you have to decide upon. That is, what is it going to be, the outcome, as in, is it going to be the infection rate or the disease rate that you are more interested in, or is it going to be the process by which that disease may happen? For example, if you're looking at infection cause spread through um, colonization in ventilators. So, do you want to assess only the infection rates in, in cases who are using ventilators, or you are also going to look at how the ventilators are managed, how the equipment is managed, the hygiene, hand hygiene being done by the caregivers, and other aspects. So, what is that you want to do surveillance on? That's what you have to decide as a key strategy. Then you have to decide on, is it going to be a hospital wide surveillance or is it going to be targeted surveillance? Hospital wide means for the same kind of infection, you want to look into every ward, every ICU, and link it with the laboratories. Whereas targeted would mean that you look into specific area? Is it particular unit or ICUs? And which infections do you want to prioritize to look for? So targeted can really focus on the main problems, and you can prioritize the resources. Hospital wide, maybe not in that much in depth, may need more resources if you want to include all the infections and track all the risk factors, whereas targeted can help you, focus and allot your resources more judiciously and focus on the important infections and places. Then you also have to look at, do you want to do surveillance of the infections and the survey or information to be collected within the hospital? Or you also want to look at post discharge surveillance, where you want to see if the infections may have manifested post discharge or some complications post discharge. It depends on what you are planning to do surveillance of. And lastly, what are you going to measure using these strategies? Are you going to measure the incidence? Then it would be a prospective in nature surveillance, where every new case have to be detected in real time. And if it is going to be prevalence, then you can in fact have periodic surveys where you go back and look at the records of last 3 months, or survey people or interview people to measure the risk of infection in the said unit or the hospital. So these are the four aspects you have to think about when you are planning the surveillance. Now, before we go on to the specific steps,
Okay, now we have the first poll.
of surveillance, I would like you all to just answer these two questions. It would hardly take a minute. So I'll read out for you while you can also select your responses on the poll, which is displayed on your screen. So question one, what is difference between hospital-wide and targeted surveillance?
Sir, is the poll visible?
Yes, yes, poll is visible.
Okay, sir.
It is that hospital surveillance is inside the hospital and targeted outside, or hospital surveillance is less costly than targeted, or hospital surveillance is for all this hospital and sites, whereas targeted is for a unit or ward or a specific disease. Or you think that there is no difference? Please read the options carefully and choose the correct answer. So what is the difference between hospital wide and targeted surveillance? Hope you have answered the question. Let me move on to the next one. Okay, question two. Which of the following is not a use of surveillance in infection prevention and control? Options are track the antibiotic resistance among known infections, early identification of outbreaks, monitoring the evidence based practices for infection prevention and control followed by the staff, or evaluation of interventions. Which of the following is not usually a specific use of surveillance? You can take some time. Which of the following is not a usual use of surveillance in infection prevention and control? Okay, I hope you all have answered, and I'll just give you the answers for this question. So, question one is a straightforward answer that hospital surveillance is for all the hospital, whereas the targeted can be for a specific unit ward or can be targeted to any specific disease. Question two, options A, B, C are definitely uh, right because you use surveillance for these measures. However, evaluation of interventions, some information from surveillance can be used. However, the evaluation calls for a different methodology and looking into in depth the processes, the outcomes, and the reasons of success. Okay, let's go to the presentation. Right. So now coming to the steps of setting up a surveillance system in hospital-acquired infections. It's basically a cycle where you plan the surveillance system, then you collect the data, you validate the data if it is correct, and you analyze the information, you interpret the information, you communicate it to the right people, they use that information for decision making, you evaluate your surveillance system, and again feed back into surveillance planning. So surveillance planning can also give feedback into evaluation system. So now for each of these steps, if we go one by one, when you're planning for surveillance, you have to define the population, the characteristics of patients or the procedures or the care providers that you are going to include in your surveillance. As I mentioned, that you have to look into outcomes or processes. Whatever you are going to do surveillance for, define those. Are you looking at acute care related outcomes or the long stay outcomes? And what kind of outcomes you are looking at? That has to be defined. Then case definitions have to be properly laid out. We suggest that you use the standard case definitions and they should be inconsistent consistent with the protocols that you have, the national or international level definitions of any disease or diagnostic criteria or measurement criteria that you are going to use. Risks assessment. Whatever you have chosen as an outcome or a disease or a procedure that you are going to do surveillance for, look at the risk factors for that and how you can assess the risk for the given parameter. Based on that, then you develop your surveillance system. In that, as I've mentioned again, that the outcome or the process, are you going for that? Then you plan a method for data collection of the outcome or the processes. If you're going for hospital wide or targeted, you collect information accordingly. I'll be going at certain details of what are the sources of information for these. Is it going to be incidence or prevalence? Or more important now is that is it going to be a routine thing? As in, as the infection is noted, it has to be reported, or is it going to be periodic in nature as a periodic survey, or even the duration? Is this going to be a routine for lifelong for the hospital, right? Or is it going to be a specific period because these days let's say we see COVID-19 infections, so we want to set up a mechanism for surveillance for hospital acquired COVID-19 infections. So what is it going to be? You have to define how long are you going to do this data collection is also important. Once you define on those parameters, then you collect the information and from your data you do data entry and do analysis. You calculate surveillance rates as per individuals or duration of stay or exposure rates, and then you can do risk stratified analysis. Do you want to look at the severe cases or mild cases who have acquired infection, those in ICU or ward, by age group, by gender, by the exposure? It's advisable that you do risk stratified analysis to make meaningful interpretations and be able to take decisions. For decisions to be made, you have to share your interpretations with clinical practitioners and decision makers who can influence the control measures. And please use this information to improve your clinical practice. Then, time and again, evaluate your surveillance system. Is it giving you what you desire out of it? Is it fulfilling the outcomes or the objectives that you have set when you started the surveillance system? And feed into your surveillance planning time and again. I want to repeat that ideally, surveillance for common infections or some resistant infections or some disease groups should be a regular phenomena in every hospital. Let's take another poll. Okay, I'll read this question for you, and you can see the poll on your screens as well, and you can mark it. There. So the question 3 is, what is not a step in establishing surveillance for healthcare acquired infections? Defined population and outcome or process indicators, having a laboratory support and reporting mechanisms, data collection and analysis, and last phase is using antibiotics uh, for any infections. What is not a step of surveillance for hospital acquired infections? Hope you have marked your answers. It might look a little confusing. So please go with a definite answers, yet you know they are true. What is not usually done, you can mark that as not a step. Okay, question 4. What kind of data collection should be done for active surveillance? Right, for active surveillance, review of monthly records by IPC team, continuous reporting from laboratory or nurse, post discharge follow up in OPD, or outbreak reports. See, active is where you actively look for the information, and usually active surveillance also helps you in uh, incidence detection, right? So please think about it and mark your answers. Okay, let me give you answers. So if you see question number 3, what is not a step in establishing surveillance for HAI? In that, first 3 are definitely steps, whereas antibiotic use is not a step in establishing surveillance. It might be a step where you inform the clinical practitioners about how the bacteria are, what is the resistance status, or rational antibiotic use. That is a decision to be taken after the surveillance is done. It's not one of the steps. However, this if you are doing surveillance of antibiotic use, then this could be answered. But in general, in the steps of setting up surveillance for hospital-acquired infections, antibiotic use is not the step. And question 4, active is when you actively seek for information, and that would be if you continuously look for infections and report from the laboratory or nurse. That would be definitely the active surveillance. However, post discharge people coming for follow up in OPD is more of a passive phenomena. Looking at the reports of outbreaks is a passive phenomena, and review of monthly records uh, is also a passive phenomena. Okay, right. So now coming to the specifics, as I mentioned that I'll come to the details. The outcome and process surveillance, to understand what should you choose, especially when you are starting with setting up the surveillance system. So the pros and cons of both the strategies are that in outcome you actually count the number of the final event, which is the healthcare acquired infection, right? So you know exactly what is the magnitude of the problem, where the colonization is, where the infection is. But the cons of this method is that you don't know what are the factors which are contributing to the problem. You don't know, you don't have many good internationally agreed definitions also for these kind of surveillance. And above all, it assumes that you have all the good diagnostic laboratory support to be able to do outcome surveillance. Many of the secondary hospitals and primary healthcare settings may not have such kind of laboratory support to be able to do outcome surveillance. So that is a limitation of it. However, at the same time, if you can focus on the processes part of surveillance, you can still manage to do surveillance of key practices and intermediate steps and control for hospital acquired infections. The pros of the process based surveillance system is that you can monitor the adherence to the practices, the evidence based practices, right? Those are the steps which contribute to the disease or prevent the disease. So if you manage to do surveillance for those, still you can contribute to reduction in hospital acquired infections. Then process is also essential to prioritize which steps to monitor, where to focus, where to allocate resources, what are contributing to the higher risk of HAIs. The cons for this method is that the reliability of this data is of question, because the reliability, the information is collected by self audits, and if you do not collect this information appropriately, then it will not be as reliable and for good use. The good compliance does not equate effectiveness. That is another thing. You may see that people are complying to the practices, but they may not be effective in nature. So, what this means is that if you do only process, then you are likely to miss on the effectiveness of it, that is in the outcomes. And if you do only outcomes, you are likely to miss upon the steps which would be contributing to the higher risk of healthcare acquired infections. So, what is advisable is that you take a decision based on the resources that you have and try to do a mix of the two. Even if you have a low resource setting, then you can focus more on the processes. However, choose one or two or a few outcome indicators, as in common infections or important infections, which you can monitor and regularly have surveillance for. Even if you do not have lab facilities of that ability in your facility, you can link your facility with the labs nearby and plan a periodic surveillance for the outcomes. So you have to look into what is the purpose and the resources that you have. Next was that if you are going to go for any hospital wide surveillance or the targeted surveillance, so what should be the source of data that you may have? So usually for hospital-wide surveillance, the source of data, if you are going for active surveillance, it is continuous in nature. You collect information continuously. It continuously is reported through medical, nursing, or laboratory records. So in that, whenever the uh, information in question or the disease in question or infection in question comes, you report it, and it continuously happens. Problem here is to be able to even establish a baseline or a control chart and to take out meaningful inferences. It will take lots of time. Usually it is prospective in nature. You calculate incidence in it, infection rates. So it takes time. And for infections which are in lower rates in those specialities, it may not be as cost effective. So, infection rates which are less frequent, or infections which are less frequent, that passive surveillance may be of more use. Anyways, now looking at other source of data. So, other source of data could be through, still it can be active, that rather than a continuous reporting, you can look at 2 weekly visits to the wards and collect information in a comprehensive manner. You can discuss with patients and staff and also look at the determinants which could be contributing to the infection rates. Okay, uh, but it is less comprehensive in a manner that if you're visiting 2 weekly, there are chances that you miss some information. But keep in mind that the purpose is to overall understand the surveillance and take decisions. So in absence of resources, you can look at ward liaisons. Then they can be laboratory based, where you look at only laboratory records, or it can be mixed. So mixed is the best approach based on the parameters that you want to do surveillance for. You look into laboratory based surveillance mixed with ward based and also some aspects of active surveillance. This approach is highly effective in detection of outbreaks and computing incidence of the diseases. Targeted surveillance, as I said, it can be site specific, as in are you looking at infections of IV cannula sites or others. can be unit specific, it can be, and you can prioritize which populations you want to look at. That is its pros, it's very flexible. But the limitations here are that you may not get effective denominator. It will be difficult to define your strategies and objectives if you keep it very site specific. If you go you by units, you may miss other clusters which may be contributing to the infections coming to your unit. Again, you may not have the denominator to appropriately calculate the rates, and you may miss outbreaks or calculate baseline infection rates. So again, if you're setting up a surveillance system for a long term, a mix of hospital based and targeted surveillance makes more sense. So what we measure, we basically measure using any surveillance method. Either we measure incidence or we measure prevalence. Incidence gives you baseline information. It allows you to identify outbreaks, allows you to identify clusters, allows you to identify risk factors. At the same time, it's very expensive, takes time, takes labor, large amount of data is collected, and it doesn't really allow very immediately to define prevention methods or prevention objectives till over a period of time you have understood what is happening. So it takes time to develop interventions. However, if at the same time in the limited resource you look at the prevalence data, it is relatively less expensive. You can use maximum information in less amount of time, and you can use this prevalence measures and do the surveillance periodically. So it will even reduce your resources. Only limitation here, what you may see, is that there can be over or underestimation of infection. People may have not recorded the information well, or they have forgotten if the infection happened or not, or if they practiced or not. So the data may not be as accurate. But again, you have to choose which indicator you are looking at and what is more feasible and useful to go for prevalence based surveillance or incidence based surveillance. Now, I'm going live. That was a recording before this. So I'll continue from the surveillance bit, but just wanted to give you an example. We will go into calculating incidence and prevalence. How do we calculate incidences and prevalences on a regular basis and plot it? Just want to give you an example from one of the projects which we analyzed, evaluated. And in this project, it is an overall project aggregate. Here, just want you to see that in project hospitals, in fact project SNCUs, they made a just looked at a record in the previous records and looked at what was the admission sepsis mortality to total admission. Out of total admissions, how many children died due to sepsis mortality? That was the indicator they calculated. The denominator is total admissions and death due to sepsis mortality is the numerator. Based on that, they calculated your indicator and then plotted it. Okay, that is the proportion they have calculated. So I just want to tell you that the project started somewhere in, let's say, January 17. The data which was collected before January 17 was retrospective, was prevalence, or looked at the records and then calculated. However, the data which was gathered after 2017, when the project started, then it was more in a prospective manner, and every sepsis case, recording for sepsis, in our SNCUs, even recording for sepsis is not properly done. So the recording for sepsis was properly done, hospital acquired infection was properly done, as well as they kept a record of every admission case and the diagnosis properly done. So in this project, they, along with the surveillance, they also did an intervention which was in the number of hospitals. which was for hand hygiene, and aseptic non-touch technique for cannulation, IV cannulation, and many other infection prevention control practices. So in the overall project hospitals, what they saw was that in last 2 years there were fluctuations. You will see these fluctuations. I hope my mouse is visible. Is my mouse visible, Srinath?
Yes, Samiksha.
Yes, ma'am.
Right. So before 2017, you see that there were fluctuations, and the median was this line, or the average was this line, and the fluctuations were happening. In 2017, when they started to record properly, you feel that the numbers are high, but simultaneously, when they were doing the interventions, slowly the proportion of deaths due to sepsis reduced in these hospitals in 1.5 years. Right? Now I'll show you another example. This is an example of one hospital. This was done in DH Khammam SNC. So here, 2014 onwards, this hospital they started intervention early, very early. So in 2014, they started intervention for hand hygiene in pre-vaginal examination in labor rooms. Sorry, in labor rooms, and then they started doing intervention for aseptic non-touch technique from early January 2016. That was both in labor room and SNCUs. And what they looked at is inborn admissions due to sepsis, right? And within the inborn admissions, death due to sepsis. So you will see that once they started doing hand hygiene properly and aseptic non-touch technique properly over a period of time, the proportion of cases admitted due to sepsis, inborn cases admitted due to sepsis, substantially reduced. So by doing surveillance and measuring the outcomes along with the interventions you are doing, you can look at the track of the outcome and what is happening. Although we do not see much reduction in mortality as such because it was anyways very low, but you can clearly see in the last 1.5 year there were no high peaks, which says that the practices were sustained and they contributed to reduction in mortality also. So this is one example of surveillance being done in District Hospital Khammam in SNCU, but linking it, marking when the interventions has been done. Okay, I hope you are trying, you understand what we mean by surveillance and how it can be useful. Here I also want to add, we have given you exercise, I guess last year, to do audits for hand hygiene and audits for aseptic non-touch technique. Apart from this surveillance, these hospitals also used regular audits, because by doing audits, they realized what were the actual lacunae in the practices. Then they filled up those gaps, and slowly improved hand hygiene every time hand hygiene was properly done. That's why it is a slow reduction in sepsis. And then further non-touch technique was used, and it was sustained. Then over a period of time, last 1.5 years, when everybody was practicing it, both in labor room and SNCUs, you see sustained reduction in admissions due to sepsis. Here it is another example of GMH Pitlabush. Here again, they started doing hand hygiene and aseptic non-touch technique in 2017. And by the end of 1 year, just in 1 year, by doing it properly, they saw reduction in admissions due to sepsis in inborn admissions. Okay, I hope this example motivates you all to uh, look into surveillance, how surveillance can really help you along with the interventions that you should be doing. Now I'm going to share another continuation of the presentation on screen. Okay. Now we were just discussing incidence and prevalence, right? So in that incidence and prevalence, we talked about that incidence is more prospective in nature. You can measure every event because you are regularly looking for it. There are less chances of missing the event, but it is very time consuming as well as resource consuming because you want to capture every information. However, it is very useful in certain sensitive indicators like outcomes or like diagnosis, recording of sepsis, right? Okay, so incidence is basically a measure which measures new cases of a disease, any new case that may be noted in the center or in your SNCU or in your labor room, or anywhere in the given population in a period of time. That is important. Both the things are important. New cases is your numerator, and denominator looks into the consideration the population, the defined population at risk in a given period of time. We'll see examples soon. Prevalence, however, talks about the number of existing cases. Like if today I look into my SNCU, how many cases of sepsis I have, how many cases of birth asphyxia I have, how many cases of respiratory distress syndrome I have, anything. So that is prevalence. Basically talks about existing cases, which includes old cases as well as new cases. That is what prevalence means. So how do we calculate them? Okay, now coming to specifically incidence. So what we commonly calculate as incidence is the numerator, the number of new cases in a given period of time. For example, in your SNCU, if you monitor and keep record of new cases of sepsis or anybody going into respiratory distress for 1 week's time and every new case is counted, then the total population at risk for sepsis would be all newborn admissions during that period of time who do not have the sepsis beforehand. Non-sepsis population admitted in your SNCU who is at risk of getting sepsis becomes your denominator. Okay, that is your cumulative incidence. Simple, you have to have a numerator is new cases of the disease that you are looking at, and denominator is the population which is at risk of getting a disease. Okay, then there is another measure of incidence which is more useful in the moving kind of population. Like a child may be admitted in a 1 week's time, which is admitted for 2 days. Should I count it in the denominator or not? How should I count it? At the same time, there is another child who has been admitted throughout the week for 7 days. Then should I count that child, for 7 days? So the duration for which the population is at risk becomes very different. Then um, in more sensitive indicators and rarer diseases and more sophisticated indicators, you may like to calculate incidence rate. See, most of you would be doing cumulative incidence, but if you uh, are looking at more sophisticated changes, if you really want to take into account for the duration the person or the child is admitted in the hospital, that will make it more sensitive indicator, that is incidence rate. So in the incidence rate, what we do is the numerator is the same, right? Number of new cases in a given period of time. But in the denominator, what we calculate is the person time of observation. For example, if a child was just there for 2 days in the SNCU within the 1 week observation period, we will count 2 days, 2 person days, 2 child days. And whereas there is a child who was just there for 3 days in the whole span of 1 week, we will count 3 person days. If the child is for whole 7 days, we will count 7 person days and we add them. 2 plus 3 plus 7. Like that, the denominator comes. Let's see an example for both of them. So for cumulative incidence, this is an example. Remember, we talked about an outbreak of P. aeruginosa in my first class on the first day. So let's say in the period of the outbreak period, in 1 week's time, they found 12 new cases of Pseudomonas aeruginosa. Sorry, this is an example in a month. In a month, August month, they found 12 new cases of Pseudomonas aeruginosa in SNCU, whereas there were 30 newborns who were admitted overall in that month, right? Including new admissions, whole admissions. There were 30 newborns who were admitted at any time uh, in that 1 month period. Not that the 30 were there present in the whole 30 days. No. Some would have been there for 2 days, some would have been there for 3 days. So if you want to calculate cumulative incidence, You can calculate it as a point proportion, or you can calculate it as percentage. It is simple. 12 into 100 divided by 30 is equal to 40%. Okay, you can calculate it easily. So the graph I showed you, in that they used to calculate monthly rates. You saw January, February, March, April, May, June. So they calculated it for every month and then plotted it in the graph. Okay, that is your simple cumulative incidence. If you want to calculate incidence rate for same population, right? So the numerator remains the same, but in denominator, just look at this bracket. I hope my mouse is visible.
Yes, yes.
Okay, so now look at this bracket. In this, out of the 30 newborns, 20 were admitted only for 3 days. Somebody would have been admitted on 2nd of that August and discharged on 5th of August. Another one would have admitted in 12th of August, then discharged on 15th of August, like that. So there were 20 children who just stayed for 3 days. There were 5 newborns who stayed just for 4 days. There were 5 newborns who lived at least for 8 days in that SNCU. So if you add all of these, 20 into 3 is 60, plus 5 into 4 is 20, 5 into 8 is 40, total you will get 120. So you calculate it as 120 percentage, and this is how you calculate, and the indicator now you get is 10 new cases of aeruginosa per 100 newborn days, or percentage in general. So this is how you calculate your indicators. The benefit of rate is, as we said, it takes into account the duration for which individual child was at risk of acquiring a healthcare associated infection. Okay, so
Uh,
incidence rate is more sophisticated. Yes, Rajan, you can add.
yeah, Samiksha, you can also expand it to infection rates, phlebitis rates for IV cannulization. So
Right.
it can be person days or procedure days, how long that procedure has been done, and then the rate of infection and the number of infections in those. So it can be either way you can calculate, and I think that is what Dr. Rangareddy was referring to on that day. Do you want to explain using one more example of? Uh,
Okay.
uh,
I don't
yeah,
have an example on the screen, but we can just take an example.
yeah,
For
or the
example,
catheterization, or yeah, urinary catheter again. The procedure days, how many days the catheter has been in place. So you sum up all the patients. So patient A had catheter for 3 days. Patient B had catheter for 5 days. Patient C had 10. Patient D had 4. So you sum up all the days of catheter, and then you look at how many events of infection were accounted in these patients who were at risk of getting healthcare acquired infection due to urinary tract catheter.
we can do it here. Let's just do it here. I hope the screen is visible and I'll type it here. It will be easier. So what Rajan is saying is, just let's take an example here. We are talking about new cases of uh, phlebitis, right, in newborns with IV cannulation. Simple. So this is what we are going to see. We are going to see phlebitis rates in the people who have got IV cannulation. So what Rajan is saying is that if you are going to calculate cumulative incidence, then let's say we got 10 new cases amongst 100 children on which we gave IV cannulation, or 100 events of IV cannulation. If you calculate that, not just, no, we should not take 100, let's just do 50. If we calculate that, so we will add a simple percentage of 20%, which is associated with the procedure. So 20% of cases or IV cannulations lead into phlebitis. That is your indicator. That's what Rajan is saying. It may not be just associated with admission. You can calculate it with the procedure of IV cannulation. right? That is one thing. If you have to calculate incidence, that is incidence rate, right? So let's say we have 10 new cases, but out of 50, 10 were on IV cannulation for 2 days, right? Then another 10 were on IV cannulation for 3 days, right? Another uh, 30, just to make it easy and quicker, 30 were on IV cannulation for 4 days, right? So how you will calculate now is you calculate what you have taken is the risk. The population is at risk for the duration for which they have been IV cannulated. So the numerator remains the same. However, the denominators become 20 plus 30 plus 120. That is 10 divided by 170. And if you calculate that in percentage, I don't know how much it will come, but it will come something like, if you multiply it by 100 also, it should be something like 6.7
Yeah, around. Yeah.
100 newborn days. If my math is anywhere closer to what my calculation is. Okay, so this is how you can calculate, right? This is the difference. You can see the difference. The cumulative incidence says that 20% of newborns who get IV cannulation will develop phlebitis, whereas the incidence rate says that 6.7 times or 6.27 newborns will develop IV phlebitis compared to the 100 newborns of risk, 100 IV newborn days of risk. Do you understand that what we are saying? So if the children have, if one child has been IV cannulated for 100 days, then its chances of getting infection is 6.7 times. Or if 100 children are IV cannulated for 1 day each, 6.7 will develop phlebitis. That is how you interpret your results. Okay, so we tell you that you begin with calculating cumulative incidence, and then you can, once you get into a habit of using cumulative incidence for surveillance, then you can go towards calculating incidence rates for more sophisticated results. Okay, now let's look at the considerations that you have to keep in mind when you are calculating incidence. That for device associated healthcare associated infection incidence rates, you need to know daily total number of patients. You can calculate it on day-to-day basis. The number of ventilator days, the example we just use for IV days. Similarly, you can have ventilator days, central line days, urinary catheter days. That's what Rajan was just telling you. And then you can sum all of those days as denominator. This is what we did in incidence rate. We actually calculated the number of days for which each child was under that procedure. Okay, that is your denominator, whereas numerator remains the number of cases or number of newborns who develop the disease. Okay, coming to prevalence. So we already said that prevalence is about measuring the disease frequency at a given point of time, includes both old and new cases. Point prevalence is when you calculate at specific time, like say today, right? You're calculating it today. So today, how many cases have hepatitis? Or today, how many cases have respiratory distress? Today, how many cases have uh, uh, jaundice? Like that. Or over a period of month also, how many cases were admitted due to jaundice? How many cases were admitted due to sepsis? That is your simple point prevalence. Period prevalence is, however, it calculates that over a period of time, how many cases and develop the disease. For example, when you started your surveillance from in month of August, so on 1st of August, there are already 3 cases of sepsis in your SNCU, and you keep measuring for another whole month. There will be some 7 new cases. So the period prevalence would be 10. But if you look at point prevalence, if you do survey on first, there'll be only 3 child. If you do the surveillance or survey on, let's say, 10th of August, maybe some what sepsis were discharged, you may never find 10 together at a given period of time. But in your records, overall there were 10 sepsis cases in the month of August. That gives you period prevalence. Okay. Period prevalence helps you to compute the resources that are required for managing such cases. So this is an example. This last exercise we'll do, and then I'll sum up with one slide and we'll close this presentation. So just bear with me. So this is just an example again to calculate prevalence. So suppose we follow a population of 150 persons. This can be people admitted in the wards or in the hospital or pediatric wards in a big hospital for 1 year. So we have just taken it for make it easy for a whole year duration. And 25 had disease of interest at the start of follow-up. Another 15 new cases developed, and 10 died during the year. Right? So this can be a population outside hospital. 1 year cases admitted is very unlikely. Just consider this is a population in a community, not in a hospital. So just for understanding. So what is the point prevalence at the start of the period? At the start of 1 year, how many cases did we have? 25. So prevalence is numerator is 25 divided by your total population, which is 150 into 100. Simple. On that first day of the year, you had 25 cases that will be used in my calculation for point prevalence. Okay. Now for period prevalence, we include both old and new cases. Does anybody want to unmute and tell me how can we calculate period prevalence? What should we count in numerator? Does anybody want to unmute and tell amongst the attendees? Lakshmi, can you, yeah, Ms. Jhansi, you also, I can see you. Do you want to unmute and tell how many cases? Yeah, Lakshmi, tell me. How many cases should we count in period prevalence?
Good evening, ma'am.
Good evening.
Ma'am, the numerator is 25 plus 15 by 150 into 100, ma'am.
Very good. Very good. So
Yes,
total
ma'am.
old and new cases. Yes, very good. This is absolutely right. Old and new cases. So that will be your 40 divided by 150. If you make it its proportion 0.27, if you multiply it by 100, 27%. Very good. Now, can anybody else, not Lakshmi, someone else, tell what is the point prevalence at the end of the period? Now, at the end of 1 year, on let's say 31st December, how many cases do we have? How many should we count on that day, 31st December of that year? Anybody wants to answer? Anybody? You can unmute yourself and talk. Or you can raise your hand and talk. Just try. No, nobody is trying. So see, there were 25 old cases, then there are 15 new cases, that makes it 40. But 10 people died in that 1 year. 40 minus 10 is 30. So at the end of the year, on 31st December, we only have 30 cases. Right? So 30 divided by 150, and we calculate our point prevalence. Can you calculate cumulative incidence in this example? Cumulative incidence is for new cases. So new cases are 15, but the catch here is that population at risk is only 125. Out of 150 people, 25 already had the disease. So they are not at risk. How many people are at risk? 150 minus 25, that is 125 who are at risk, and then you calculate your cumulative incidence. So you have to be careful when you look at your numerator and your denominator. Okay, so it was just about incidence and prevalence, but you can similarly calculate morbidity rates. Attack rate is usually calculated in outbreaks. It is similar to incidence, cumulative incidence, and mortality rates. Like in your surveillance example that we used death rate, we use cause-specific death rate, right? Death due to sepsis. Case fatality rate can also be used, which is out of total sepsis admissions, how many died due to sepsis, right? So those are other indicators which you can calculate and use in your surveillance, depending on how you want to measure it, right? Okay. So last slide here. Important considerations for surveillance, that all types of surveillance are expensive and time consuming. So be careful and define as much as you can your objectives, your indicators, and ensure that all the team members agree to it, including the clinical teams, right? Not just that the survey people or the committee or the infection control team wants to do it. Somebody also has to report, diagnose, and report and record. So everybody should agree to those objectives and definitions. Ensure that before you start surveillance, you have all the resources and supplies available, and they should be available throughout the period of surveillance. Okay, the people who are involved in surveillance, they should be identified, their roles and responsibilities should be defined, and they should be trained before they start surveillance. About use of data, quality of data, there is a different aspect in surveillance which needs to be talked, and we should be talked maybe in subsequent webinars or when we do mentoring, that you should also look at your data and quality. You should validate your data, analyze it periodically so that you can use the information in timely manner, interpret it wisely, right? Just see what the data says, right? Take out meanings from it which can help you in operational decisions, and share the information with all important stakeholders in time when you can actually make a difference. So surveillance is very important, and it is about information that needs to be used for action. Okay, so that is all from my side, Srinath. You can summarize and then we can take quick questions.
Yes, ma'am, sure.
Yeah.
సో ఇప్పుడు మనము ఈ ప్రెజెంటేషన్ లో ముందుగా సర్వేలెన్స్ గురించి మాట్లాడుకున్నాము. హాస్పిటల్ అక్వైర్డ్ ఇన్ఫెక్షన్స్ యొక్క ట్రాకింగ్ కోసం సర్వేలెన్స్ అనేది చాలా అవసరం ఉంటుంది. జనాభాలో ఎక్కువ ప్రమాదం ఉన్న వాళ్ళని అంచనా వేయండి. అంటే ఎవరికైతే ఎక్కువ ప్రమాదం ఉంది వాళ్ళకు మనం ముందస్తుగానే అంచనా వేసుకొని పెట్టుకోవాలి. నిఘా కోసం స్ట్రాటజీ అనేది నిర్ధారించుకోవాలి. ఒక దగ్గర మనం సర్వేలెన్స్ చేయాలంటే దానికోసం మనకు ఎలాంటి స్ట్రాటజీ కావాలో అనేది మనము చూడాలి. అలాగే దాని తర్వాత మనము ఇన్సిడెన్స్ మరియు ప్రివలెన్స్ గురించి కూడా మాట్లాడుకున్నాం. అందులో మనము చూసింది ఇన్సిడెన్స్ అంటే ఏ కొత్త కేసులు వస్తున్నాయి, కొత్త కేసులు ఎలా వస్తున్నాయి, ఏ టైంలో వస్తున్నాయి అనేది మనము దాంతో చూడొచ్చు. అలాగే ప్రివలెన్స్ అంటే పాత కేసులు మరియు కొత్త కేసులు రెండు కలిపితే ఎన్ని కేసెస్ ఉన్నాయి ఒక పాయింట్ ఆఫ్ టైం కి కానీ లేదంటే ఒక పీరియడ్ ఆఫ్ టైం కి కానీ అది కూడా మనము ప్రివలెన్స్ ద్వారా చూడొచ్చు. అలాగే మనము క్యూములేటివ్ ఇన్సిడెన్స్ ఇంకా ఇన్సిడెన్స్ రేట్ గురించి కూడా మాట్లాడుకున్నాము. దాని తర్వాత మనము డేటా కలెక్ట్, డినామినేటర్ డేటా అంటే ఎలాంటి డేటా మనము కలెక్ట్ చేయాలి దాని గురించి కూడా మనము మాట్లాడుకున్నాము. అదే విధంగా మనము ఇన్సిడెన్స్ ఇంకా ప్రివలెన్స్ ఏవైతే ఉన్నాయో అవి కేస్ కి మాత్రమే కాకుండా మిగతా ఇన్ఫెక్షన్ కి కూడా ఎలా చేయాలి అనేది కూడా మనము మాట్లాడుకున్నాము.
Srinath, I
Yes,
request
sir.
you to play the video and
Yes,
then
sir.
we'll call in Samiksha. Yeah.
Yes, sir. I'm just playing the video.